I'm Stephen Hall, and I'm really excited to be here with Larry Libman. He's been involved in EECP for, what, 30 years or 40 years?
No, I'm not that old.
Okay.
A little over 20,
long time.
Almost 25.
Okay. So he's going to kind of walk us through a few of the bits and pieces, some of the things that people ask me all the time. And the first one, I'd love to know a little bit more about the history, who developed it, where it was developed, and where it's been very effective.
Okay. Well, the story is, it's an interesting story. It started actually back, even though EECP wasn't introduced to the market until 1995, when it got its market clearance from the FDA. Its history goes back to the 1950s, believe it or not.
Wow.
When cardiovascular surgeons were doing surgery up at Harvard and MIT and their affiliated hospitals, the top cardiovascular surgeons noticed that the heart didn't get its blood flow when it beat it. When the heart beat, blood was forced out of the heart to the rest of the body. The heart received its blood flow when it went into the resting phase, or diastole. So what we refer to as systole, when the heart beats, blood goes out all the way, and then when it starts to rest, it's diastole. So they figured if we could get blood back into the heart, it would help the heart muscle, and maybe we could override some of the blockages in the heart. So what they worked on with a physicist was developing first an external system of cuffs. They were actually, believe it or not, they looked like iron lungs for the legs. It was basically iron legs with water-filled bladders or balloons inside. Wow. And what they tried to do is time the inflation of the water to those balloons so that they would squeeze the leg, much like a stress ball, so that the blood would then go up the body, retrograde flow up to the heart. That was the early devices for external counterpulsation. That progressed over the years to developing an intra-aortic balloon pump. They found that they could stick a catheter into the heart, leave it in the aorta, and just by pumping and increasing blood flow to the heart, they could help the heart during periods of, like when they were doing surgery and the patient would come off the balloon, off of, anesthesia and everything. Their heart wasn't strong enough to support it. The intra-aortic balloon pump did it. Well, they kind of diverged into two different camps. And that's one of the reasons why EECP isn't as well known as it is, because obviously the guys with the toys are the guys who make the rules in the hospitals, the cardiovascular surgeons. And they like the balloons and they like the catheters. And the same thing with cardiologists, who then were given the ability, after surgeons were inserting balloons and catheters, to then do it percutaneously through the skin, and they started to do angioplasty. So you got cardiovascular surgeons making more money doing surgery with intra-aortic balloon pumps, and you got cardiologists wanting to put in, do angioplasty, and then the development of stents, and they can make even more money. So one of the reasons why EECP was kind of left to the side is these were the guys who were making the rules in the hospitals. So the people who picked up on it and who adopted it, interesting enough, during the 70s, were people in China who had large numbers of patients with cardiovascular disease and could not do all the surgeries, didn't have the money, didn't have the expertise, didn't have the knowledge to do angioplasty and stenting. EECP was perfect for them.
Yeah.
So what they did is they developed a form of external counterpulsation, and with the advent of computer chips and the ability to synchronize, they were able to get closer to the heart's resting phase, the diastole phase. Well, they were doing work in China. There was a doctor, one of the original physicists who worked with surgeons at MIT and Harvard, went to Stony Brook, and he was working with a Chinese physicist. And this physicist had a contact at Sun Yat-sen University in China, and they started working together, and that's how they developed enhanced external counterpulsation with the most modern techniques. and finally introduced it in 1995.
Wow.
So it seems like it was an overnight thing, but it really wasn't. It was a long progression of development. And the interesting thing is that the guy who was the Chinese PhD physicist at Stony Brook was Professor John Huey, who became the first president and started Basel Medical, which is a company that I work with for almost 25 years.
I see. Okay. Well, that gives us a good idea of getting it to Stony Brook. What happened after that? I mean, I know the cardiologists I know, they went through a long process of trying to find how they could turn a vein into an artery. That was a good 5-10-year process trying to figure that one out.
Yep. But you're still talking about invasive procedures. And that's the unique advantage of EECP. EECP is a non-invasive therapy. And over the years in development, they also learned a few other things. Not only did the heart receive its blood flow and increased blood flow at a higher pressure during the pumping phase, so the diastolic phase, they found out that by doing this in this retrograde flow, as it's going through the entire cardiovascular system, the blood is rushing against the side of the walls of the vessels. Those vessels align with endothelial cells. Those endothelial cells, with normal aging, more so with disease, stop functioning normally. So what happens is they don't move very well. They get stiff. The vessel gets stiff. There's no new vessels being developed. And that's how people wind up with arterial sclerosis or the hardening of the arteries.
Hardening of the arteries, yep.
It's a natural process over age. It's basically, age is almost like a disease. And that aging process is exacerbated by people who have risk factors, people who smoke, people who drink excessively, people who don't eat properly, people who don't exercise. When they do that in their lifestyle, they make it even worse. So they enhance the stiffening of the arteries. And by the way it actually works is if you took a single cell, endothelial cell, and put it in a petri dish, it would just sit there. And that's what's happening with these dormant cells in the arteries. They're not doing anything, they're stiff. Well, here we go, and if you took it in the cell in the petri dish and you blew over it and excited the cell, it would start to move. So what's happening in the vessels and the lining of all these endothelial cells is that the blood rushing alongside of it, which is called shear stress, that natural stress causes the endothelial cells to come alive. And what do? They produce nitric oxide, which is a vasodilator. We know about that, mostly in men's health from Viagra. That's the key ingredient.
That's the key ingredient, Viagra, isn't it? NOx.
It increases vascularity. But what also has happened, and there have been studies coming out of some of the major institutions around the United States and actually internationally, demonstrating that this shear effect not only releases nitric oxide, but causes those cells now to start to release what's called CD35, CD34. These are stem cells. And as those cells are released, those are the cells that are needed to form new blood vessels and enhance. Give you an idea. If we have a river feeding a cornfield, and then we build a dam, or somebody builds a dam on that cornfield's going to dry up and it's going to die, very much like what is happening to the cardiovascular system. If we increase the pressure behind that dam and force the water to go over the dam or around the dam, it will create tributaries of that river. And that will now irrigate the entire cornfield, which will come alive again. And that's what happens with EECP. That increased pressure increasing of the gradient pressure and increase of the shear stress causes, over the period of time, over the normal regimen, which is 35 hours, usually delivered 1 hour a day, 5 days a week for 7 weeks, or some variation of that. Sometimes patients want to quicken that up. They can do 2 a day as long as they separate it with a half hour in between, because otherwise they get really tired. But that's what's happening. The cardiovascular system is improving. So rather than looking at invasive procedures like CABG, coronary artery bypass surgery, or stenting and angioplasty, which are designed to treat the lesion, either bypass it or put something through it. What EECP does is increase the blood flow around the heart, but it's also improving the entire circulatory system. And as it, absolutely, it's totally holistic, because now it's going not only to increase the entire cardiovascular system from head to foot, but it's increasing the organs that blood is going into, because the organs have smaller cardiovascular systems. So what's happening is we're finding, and maybe too soon to go into, but this is the understanding of why there are off-label uses of this. There are studies that have demonstrated these off-label uses, and we call them off-label uses because they're not cleared by the FDA. The FDA has only cleared EECP for use in treating patients with cardiovascular disease, with refractory angina, patients who are not amenable to the invasive surgical procedures or the medication. They're not getting help, or even they've had a bypass surgery or an angioplasty, and they're still symptomatic.
Sure.
Because sometimes they don't get to all the blockages.
Yeah, I want to stop you there for a second.
Okay.
You used a word called CABG, which stands for bypass surgery.
Yeah, coronary artery bypass surgery.
Right. So if I watch bypass surgery on the internet, the first thing they do is take a jigsaw and split your ribs down here and take a rib splitter so they can get to your heart. Isn't that the first thing they do?
Well, that's actually the second thing. The first thing they do is open up your legs and take veins from there. So they're either going to take the saphenous veins out of the legs, which then sometimes create problems because you've got a patient who's got cardiovascular compromise to begin with. And now you're going to take one of the veins out. Now there might be two others still there, but you're still compromising that a little bit. So that's another issue for the patient to deal with. And then you are going to open up the chest, because if they don't take it out of the leg, they're going to take the mammary vessels, the mammary veins, and that's what they use instead. So the patient's having more surgery than also opening up the sternum, splitting that open, and that's quite an extensive healing process. It's an easily 6-month healing process before the patient can start to get back into rehab or something like that.
And that's if you're strong. If you've got other complications, it could...
Absolutely. If you've actually, part of the FDA guidelines talks about EECP is appropriate for patients who have comorbid disease. And the comorbid diseases are things like, for instance, if they have peripheral vascular disease already in their legs, you don't want to take veins out. If they have cardiac anomalies, their anatomy isn't good for doing the type of surgery. Maybe they've had surgery already and they can't find additional, what they call target sites, where they're going to put the graft on one side of the blockage and where they're going to put the graft on the other side of the blockage to bypass it. So you also have patients who have, dementia. As patients are getting older, they have the onset of that or the beginning of that. You don't want to put those patients under anesthesia if you can avoid it for many, many hours. Coming back out, the body is really, as you described it, opening up the chest, but it's a shock to the whole system. And anesthesia and coming out of that process is a very difficult process. Angioplasty,
You're going on a heart-lung machine for a minimum of 4 hours.
Well,
if I understand
sometimes
correctly.
they do off bypass surgeries as well now. And to do, we'll say, for instance, a patient's got, there are 3 main vessels in the heart. There's a right artery, left artery, and there's a circumflex artery. Circumflex artery sometimes goes around the back. The blockages are in the back, and they can do the first 2 blockages, with a patient off bypass. They won't put them on bypass. They'll do the surgical things first, and then they'll make, and they'll do that. And if there's a choice, and it happened with my own mom, when she had bypass surgery at 85, they did 2 vessels and then decided, she's really getting weak. Her lungs aren't able to, exchange gases the way it needs to. They want to take her off anesthesia. So they never got to the blockage in the back. So even though she's had bypass surgery, she's still having symptoms of angina. So that's one of the reasons for enhanced external counterpulsation, because those patients don't want to have their chest cracked a second time.
Nope. I don't even want to have
it would be
time.
unhealthy. It would be unhealthy to go in for those patients. Their procedure, the process is too difficult. And there are some cardiologists, some cardiovascular surgeons who will just flat out refuse to do it.
Yeah.
Some will, but some will refuse.
Yeah, it's incredible what they can do. It's absolutely incredible. It's so invasive. I don't even know what the death factor is on it, but I'm sure it's a hell of a lot higher than.
It's not only the mortality factor, it's the complications afterwards.
Yeah.
Sometimes you've got to look at almost 6 months, post-surgically, to make sure that there's no leaking of sutures, there's no, and these patients, because they don't feel strong going in, they're going to feel even worse coming out.
Yeah.
And what are they going to do? They're going to sit on the couch. They're going to watch TV.
Yep.
When I'm sitting on the couch, I want to eat. I want to smoke. They're not able to do the things that they would normally do. They're not able to go down for the mail. They're not able to go shopping. They're not able to play with their grandkids. So, that's one thing. And all of these patients are dealing with this before a procedure to relieve symptoms. Why put them through it for, extend that?
Their quality of life is not good to start with, and this doesn't enhance it in any way, shape, or form. So one of the things that I'm understanding here is, the conventional cardiologist, angioplasty and the bypasses are very invasive, whereas EECP is non-invasive.
Right.
So there's, when you've got a choice between invasive and non-invasive, I know which one I'll choose to try first. And if it's successful, I would go with that. Every time I talk to somebody about this and ask that question, would you like the invasive or the non-invasive first? They're always going, well, non-invasive, obviously. And why haven't I heard about this before? If I knew about this, this could have saved my brother, my sister, my mother.
Absolutely. Absolutely. Something, we've even had people that we've talked to who was talking to his cardiologist after his bypass surgery. And he had found out about EECP through a friend of the company who asked him to come down and, and talk to us about it. And we presented it to him. And at his next visit to his cardiologist, he asked, why didn't you tell me about it? He said, to be honest with you, I didn't think about it at the time. He says, I actually have a system in the next room. That was his last visit to that cardiologist. Some doctors just don't think about it. My own cardiologist in New York, before I retired and moved down to Florida, my own cardiologist was a highly invasive cardiologist. And I knew that I had had a heart attack at 38. I had angioplasty. When I moved from Boston to New York, it was after having angioplasty up at Mass General. I moved to New York and I looked for a cardiologist who was invasive because in my mind, that was what I was going to need in the future. And I found somebody who's excellent at St. Francis, one of the best, cardiovascular disease hospitals on the East Coast, if not in the United States. Mm-hmm. Very high success rate, even with cardiovascular surgery, and they take all comers. which is unique. They do not refuse patients and handpick them. Long story short, my cardiologist calls me in one day and he says to me, you've been bugging me for years about this EECP. He said, why don't you bring me the literature? If you can put the papers on a CD so I could look at them over the weekend. I said, why the change? He said, well, I've been doing this for so long. He said, and I'm seeing patients that I wind up with back in the hospital over and over again. He says, and I don't think they're getting any better. He says, so I tried behavior modification. I tried weight reduction. I tried, changing their diets and all that. He said, I still didn't see a significant improvement. I want to try EECP. So what we're going to do is I'm going to buy one system. I'm going to put it in one of my exam rooms. If it works, I'm going to take the offices next door and I'm going to put in 4 systems. So what he did was he got the first system first. And what I asked him to do is put an index card in his pocket. And instead of just talking to this patient across the table and thinking about the patient in the next room, think, is this an appropriate patient? If they have angina, of course, is this an appropriate patient for EECP? So he started writing names down on his index card. And before we closed the deal, he said to me, what's the price if I buy 4 systems? Because he
filled up the whole card.
Well, I'm telling you, for 4 years, he ran 4 systems. He started treating patients at 6:30 in the morning, and the last patient got off the table at 9:30 at night. Wow. They started in the dark and they ended in the dark in the wintertime. He treated not only patients, once he started connecting the dots and looking at the scientific evidence, and this is what happens with most physicians. We spend a lot of time trying to educate and convince physicians to do this, but once and every physician I sold, I said to him, I know you're going to laugh at this, but before you sign the purchase order, think about where you're going to put your second system. Because if you think about one system, you're going to treat patients for 1 hour a day. The most you're going to treat is 6 to 7 patients. Mm-hmm. Now, it's a 7-week cycle. Let's say, regarding forget holidays and everything, the most cycles you're going to have are 7 cycles, 49 weeks. Not exactly 50, but it's close enough. So 7 cycles times 5 or 6 patients, you're only going to treat 35 to 42 patients. He had something like 500 patients in his practice. So you can imagine how his index cards filled up real fast.
Yeah.
And he had a perpetual waiting list. As soon as a patient came off, he had another one going back on or starting. And that's the way a lot of the practices, what we found after the first couple of years were a little bit tough because there was no reimbursement when we first started.
Yeah.
There's no reimbursement, and there was only 2 clinical studies out of Stony Brook. Now everybody pays for it, and there's something like almost 250, 280 clinical studies published in medical journals about EECP. Incredible. However, one of the things that is also, remembering what I said before about cardiovascular surgeons and cardiologists who are not necessarily opposed to EECP, but prefer, the other procedures where they make more money. Even the hospitals, they have to feed the hospitals. They have to feed those expensive operating rooms. They have to feed those expensive cath labs. And if they want to keep their privileges, they have to keep a certain number up. So this is a business. Yeah. When the Affordable Care Act was passed, and regardless of whether you're a fan of that or not, one of the things in the Affordable Care Act wanted to improve the way care was provided for patients. So they picked 3 diseases, and they picked angina, I think they picked acute MI, and pneumonia or something, I forget what the third one was. And they said, we're going to track hospitals. And if you get if you have to readmit your patients within 30 days for either congestive heart failure, acute MI, and this third, we're going to rank you according to the other hospitals. And the hospitals that fall in the lowest quartile every year will lose 1% of the Medicare budget as a fine. Second year, 2%. Third year, 3%. That's the total overall Medicare budget. You know that the hospitals make more money keeping 100% priority. They gladly paid the fines. So, you know, when you're up against that kind of resistance, you have to find physicians who are willing to listen and connect the dots themselves. And the guys that we've dealt with over the years are not only great diagnosticians, but think about their patients. They think about how the patient is being dealt with as a holistic view. They want a better lifestyle for them. They want to improve their quality of life, and that's the key. And that's even in the clinical studies. The MUST study, which was the first clinical study that, you know, was a randomized, multi-center, blinded, controlled clinical study, had an arm of it which did the quality of life studies, what they call the SF-36 forms. And it showed that there was a significant improvement in the quality of life of patients with EECP as opposed to bypass surgery or patients who had no treatments whatsoever. So, you know,
so that's the reason why we don't hear about EECP more, is it's basically a financial
that's key, and it's also the standard that some of the agencies, both you know, not so much you know, at the FDA, but certainly Medicare, applies the same standards to all medical equipment and testing that they do to drugs, which are absolutely absurd. A drug company with billions of dollars can go out and get 10,000 patients in 6 months and do a clinical study, and within a year, they get their approval for, you know, for going to market and being paid. You can't do that with a medical device like a ECP machine if you're only treating 50 patients a year on it.
Yeah. Yeah.
So the clinical studies that are published in medical journals, while they're significantly convincing, and they're directional, meaning they all show the same type of results. 75 to 80% of the patients improve significantly, 50% improve moderately, and another 25% improve, you know, just, you know, minimally. But everybody improves. Those studies and stuff like that were smaller numbers. So even if you put them together, they all don't have the same endpoints. They're all not organized the same way. So the FDA, and especially Medicare, won't accept that. And that was one of the reasons why, even though it was previously approved for congestive heart failure, they took that approval or indication away. They said, oh no, you got to do a big study. And that study could cost the companies millions of dollars, and none of the manufacturers were that big to do those kind of studies. So they said, we're just going to keep in our market in angina. And, you know, for those patients, those physicians who want to make the determination to use it for the other cardiovascular diseases, physicians can make that determination. Manufacturers can't go out and promote it.
Right. So I want to ask you, over the last, 50 or 60 years of history of this, there's been a lot of studies that have shown off-label benefits. The ones that I'm thinking of is there's 4 studies on ED.
Right.
That were very impressive to me, because I mean, you know, if you've got cardiovascular disease, ED is part of the package pretty much.
Mm-hmm. Because the cardiovascular system is feeding the entire body. I mean, it's the largest organ is the skin. And, you know, even the vessels that flow through the skin, vessels that flow, EECP in clinical studies demonstrated that it improved blood flow to the kidneys by 40%. What is 40% of the blood flow? That's opening up vessels. The kidneys are functioning, if not functioning better, it's stopping the progression of kidney disease.
Wow.
There were papers published, how improved blood flow helped patients with cirrhosis of the liver. There's a whole network. In fact, it was actually approved by the American Society. It's called, it's basically the Stroke Journal, which is another part of cardiovascular disease under cardiology. But there are, the American College of Cardiology has approved EECP, or is included in the guidelines. They did research in 2012. They had formed a group in 2010, and this group looked at all the literature from 2008 forward. I mean backward, since the beginning. It did not look at anything past 2008. So they came up and they said, well, we think it might be considered, and we should put it in the guidelines for physicians to consider. But we'll put it in at a recommendation level B, which means it might be done or it can be used. Or in the doctors in stroke also put it in their guidelines with a level B, looking at the same documentation. However, in Europe, when the European Society of Cardiology set up a task force to look at EECP for consideration of the guidelines, they took everything from 2013 backwards. And in 2010, 11, 12, 13, there was a lot of literature that came out showing the benefits of EECP and how it works, and answering the questions of cardiologists. I don't understand how it works. So once they saw that, they put it in the European guidelines with a level A recommendation, which means it should be considered prior to angioplasty or bypass.
Wow.
So, again, the question of why people don't know about it, why they don't use it, is all a matter of what information you've been provided and who you got it from.
Mm-hmm.
So, and that's what made, for us, trying to sell EECP difficult, because you couldn't get a massive wave of information to a doctor unless you went in and you individually explained it to them.
Sure. And if I understand correctly, the FDA's major job is to keep things safe, and their easiest thing to do is to test drugs. So, I mean, giving somebody a drug and somebody a pseudo drug is real easy to say, yes, no, it works.
It's cut and dry.
EECP, you can't give somebody a treatment and a pseudo treatment, really.
Well, we did actually in the MUST treatment, which was what was really interesting. And there's some other studies since then that they split the two groups. They did, in the MUST study, they randomized people as they came in to group A or group B. Group A was patients with active EECP treatment. Patients with group B were put on the table, but the knob that controls inflation was never turned up. So when the machine was turned on and the cuffs inflated and deflated, they thought they were getting a treatment because they didn't know any better. But they were actually getting a placebo effect.
Wow.
So despite that placebo effect, because patients were coming to the office, they were talking to their doctor, they were seeing somebody on a daily basis, and they had the advantages of pre-tests, and then they think there's something that's benefiting them. Some of them in their quality of life actually showed they felt better. They didn't have the symptoms.
They weren't getting the real thing. They
weren't getting the real thing. They weren't getting the real thing. After treatment stopped, all of those patients said, the ones who said they had a lessening of symptoms, their symptoms came back full force, and they wound up coming back to the practice and asking, can I now get the real treatment? So there was a huge crossover at the end of it. A lot of studies now also do EECP against no treatment. Just treating the patient, keeping them. The PEACH study was a study comparing patients who had congestive heart failure and just keeping them on their normal regimen of medication and then treating with EECP. And a minimum, basically, it had good results. It was supposed to, and here's, unless it's actually explained, physicians thought that the endpoints, one was the improvement in exercise. The other one was an improvement in what they call VO2, oxygenation.
Mm-hmm.
When they looked at the whole group of these patients with congestive heart failure included patients of all ages. So you had a lot of younger patients, number one. Number two, medications at that time, they started putting patients with congestive heart failure on beta blockers so that they couldn't, beta blockers almost like a medication that's a governor. It limits you putting so much stress on your heart. So the results were, even though all the patients improved significantly in exercise tolerance, they didn't improve the way they expected them to improve in max VO2. Well, the endpoints was supposed to be either or. People assumed that it was only half successful. So they didn't accept PEACH as a significant clinical study, even though it was. And what they did afterwards is the PEACH investigators went back into the study, back into the data, culled out all the patients over 65 and looked at this group of elderly patients. All of them improved significantly, and we're talking about class to class, group against group. All of them improved statistically significantly in exercise tolerance and in oxygenation. They all improved in, there was also quality of life in that as well. There's a study called Minnesota Heart Scale for measuring patients on heart failure, and that significantly improved. So, with very few exceptions, I think there might be one or two papers out there where their researchers, based on the protocol that they did, didn't see a statistical improvement. The other 280 did. So, and that's always the question when somebody has said to me, or I've said to a physician, about a clinical study that didn't demonstrate what it was supposed to or expected to. The first question is, tell me about the protocol. Because show you how strong EECP was in that MUST study, where patients were not supposed to get treatment and some were supposed to get treatment. We found that by visiting the clinical sites, sometimes the therapist felt sorry for the patients who were still having pain, but were in the non-treatment group, and they would sneak them a little extra treatment to make them feel better.
Oh no.
So it almost defeated the purpose of the study, but the study and the EECP was so strong, it still showed statistical significance between the two groups.
Yeah.
It also showed a significant reduction in angina episodes, and it showed a statistically significant reduction, but not between the groups, in the use of nitrates, because some patients, even though they had active EECP, their way of taking nitro was before they got pain. So if they were going out for a walk, they would pop a nitro. If they were going to take a shower, they'd pop a nitro. So it took them for a while to realize that, hey, I'm not having pains anymore. Maybe I should cut back on my nitro. And then they realized that they didn't need it. And actually, one of the doctors who became a very strong supporter of EECP came back from a ski trip. And he said, I just went up to Whistler up in Canada. He said, and now I know that EECP works. I said, how do you know? He said, well, I had a couple of weeks of treatment before I went skiing. He said, and for some reason, I forgot my nitro. He says, I skied all the slopes I normally ski. I had no angina. So you know, these are the things, and this is why even after 3 years, 4 years of retirement now, I'm still talking about this therapy, because you see the improvements in people's lives that is so significant that you can't help it. And I've never, I worked in the industry almost 20 years before I came to EECP. I started out selling pharmaceuticals, and then I went into laboratories, and then I went into selling x-ray and patient monitors, and I used to sell ICUs and CCUs, but never did I get involved in anything where doctors would call me, or they'd come up to me at major, you know, national shows that we would go to, and they go, I got to tell you about this patient. You know, this patient was on 24-hour O2. This patient was, you know, in a wheelchair. I treated him with EECP, didn't see him for 6 months, and I thought, God forbid, maybe he passed away. And I walked into my office, and there he is one day standing with a cane. He goes, I don't take nitro anymore. I just keep the cane for balance. He said, I haven't had pain since the treatment.
Wow.
So when they see patients like that, they get excited about it. They start to think about more patients, and that's where the multiple systems come in. They got to treat more patients.
Yeah, I had a couple of experiences with the one gal that I've known for years. She travels a lot, and she's got very bad edema in her legs. And so she said, you know, anytime she does an international flight, she schedules a day or two afterwards to recover. And I suggested to her, there's a facility right by LAX. Before you fly to Vietnam this time, go get a treatment. She went and got a treatment. She arrived in Vietnam. She didn't have the edema that she normally does.
I've done that personally, because I traveled to about 40 different countries for vasomedical and, you know, promoting EECP. And those long distance flights to the Middle East or to, you know, Southeast Asia, or even to some of the places in Russia, you know, I would wind up with having to, you know, lay in a bed with my feet up the wall, trying to get the swelling from my ankles down, taking everything out of the mini bar that was cold around my ankles, trying to reduce the swelling. First thing I ever did when I went to a show is put the table together myself and get on it and make sure it was working for the show, but also to get a treatment. And I would do it before the show, get there early, and I would stay after the show.
Well, I've done shows before. It's a killer standing up all that time, yeah.
Oh yeah, and I would just use it on my cuffs, my calves. I didn't even do the full cuffs. I'll share my personal experience with you. I can't talk about other patients, but I can share mine. Yeah. A couple of years ago, before I retired, I was finding myself getting out of breath, and really couldn't get upstairs the way I used to. I used to go up to our second floor two stairs at a time to see Dr. Yui, who was the founder. He always wanted to stay upstairs, you know, in a private room in the back where he did his research. Long story short, I went to my cardiologist, and he said, we got to do a stress echo. And they do a stress echo, and he said, you know, I don't like the looks of the stress echo because looks like your ejection fraction is down to about 38%. It should be around 55.
Yeah.
I said, you know, I don't want to do anything invasive. You know me. He said, well, you know, we have the systems here. Why don't you come in and get treatment? So every morning at 7:30, I was on a bed getting treated for 7 weeks. I mean, this is not using it now for fun or helping my legs or something like that. I'm being treated as a patient. And because not only do you have chest pain, but angina is also classified by the American College of Cardiology is for patients who have atypical pain in the arm, shoulder, jaw, patients who are fatigued, and patients who are out of breath who don't have a pulmonary problem. So I decided to go through the full course of therapy. At that point, he decided then let's do an angiogram. By going in and doing the angiogram, they were able to then do an invasive cardiac output and my cardiac output went from 38 to 58.
Wow.
And it also, and that's a period of time right after I was recovering from lymphoma. So that was one of the reasons for, you know, me coming back to work and feeling tired and everything like that, because I had laid around a lot. I wasn't very active. My travel had stopped for a while. Now, after this, I went back to playing tennis, playing golf, and traveling again. And that's when I decided after that, a couple of years of that, to then retire. I'm down in Florida now. I play tennis or pickleball every single morning. I play golf and I swim every afternoon.
Right.
So, and I'm 73. So
That's good.
It works.
You brought up something, you said lymphoma. Now, this is one thing that I've learned about, is not only do we have a cardiovascular system, which has 5 liters of fluid that's pumped around your body 10,000 times or more a day, you have a lymph system that has 20 liters of fluid, and it doesn't have a pump. Now,
right, the only thing that actually moves lymph around is your respiration. That's the only thing that does. By adding EECP, you know, to a patient's therapy, and having the 3 cuffs on the legs, the calf, lower thigh, upper thigh, and buttock, you're not only evacuating all the blood vessels, but you're moving everything out of the tissues. And by doing it, the way this works most effectively, we talked before about the pressure and how it works effectively for the heart, is it moves everything out of the cells. So it exchanges the cells, not only the blood, you know, the gases and the lymph, and moves them upstream the way they're supposed to be working. So it's a training effect as well, because when it does this, the heart doesn't have to work as hard to push it around. It's actually going back up to the heart with assistance, and that's why they call it a cardiac assist device, because it's assisting the heart in returning blood flow, increasing volume, and decreasing the amount of heart work, or they call it the workload that the heart has to do. So the heart's not consuming as much oxygen in the muscles. The muscles are working more effectively. The muscles are being trained just like you train any other muscle. So it's a EECP works in so many different levels that it's, you know, it's amazing. It works from the physicality, through the chemistries, through the normalization of the hormonal cascade and the way the body's supposed to work. It is almost, and there are some doctors who have used this quite successfully in talking about it in the world of anti-aging, because aging is a progression of disease. We're getting older, the cells get older, they die, they exchange. But if we can slow down, retard, or stop that process, then we don't have to wait until we have organ failure before we do something about it.
right.
So ECP can be and should be used preventively as well.
So what I understand in the basics, you know, I'm not a doctor, but the EECP gets you better vitamins, minerals, oxygen to the cells through the cardiovascular system. And then what
it's doing is by increasing this blood flow.
Right. The blood's delivery vehicle.
The endothelial cells are functioning better. They're giving up stuff they're supposed to give up, and they're ready to absorb more.
Right.
The same way the heart, when it doesn't have to work so hard to pump, it opens up and it pumps out blood. Then the vessels that are trying, the venous system that's trying to get blood back up into the heart, because it goes to the atrium first in the heart. Those are the smaller chambers of the heart, and then goes to the lungs, gets oxygenated, then goes back to the heart into the ventricles, and then when the heart pumps, that's when all that oxygenated blood goes back out to the rest of the body. So the more we can, it's like when you do ECP, it's almost like having a second pump working, but it improves that first pump, so then it can operate effectively on its own.
Wow. So we're increasing all the good stuff to the cells.
Absolutely.
Also, you're stimulating the lymph system to get rid of all the bad stuff at the same
Absolutely.
time. So we're
Yep.
removing the waste product, in other words, lymph drainage, and we're giving it the good stuff on this side. So not only are we enhancing the blood and minerals and everything here, we're removing all the toxic waste. From the
Absolutely.
body
And where's
at the
it
same
going?
time.
It's going to the body's filter system. It's going to the kidneys. That's why patients on EECP, we advise patients to go to the restroom first before they get on the table, because moving all this fluid around and getting it out of the system is actually going to require them, as soon as they get off the table, to go empty their bladders, because now their bladder is going to be full again.
Yeah. So we're doing a wonderful thing for the human condition.
Oh, absolutely. Absolutely.
So one of the things that I was very impressed about is quality of life. I mean, the other client that I had that came to me, he had about 5% feeling in his feet. He's a diabetic.
Mm-hmm.
He'd fallen down over forward, tumbled about 20 feet, and E19, he fractured it, compound fracture, broke his back. So what he came and he said, can I get some more balance, more feeling in my feet? After 35 sessions, he got retested at 50%. And I mean, he used to walk like this, you know, like you see the little old men waddling down the road. And when he was done, I mean, it was 1 foot in front of the other. And his exercise tolerance went up like 15, 20%.
Oh, significantly. If you improve that blood flow, back to the legs, the microcirculation, and that's where the problem is. It's distally down, you know, in the smaller vessels. That's why here's a comparative study for you that really makes sense. If you looked at diabetic patients who go for bypass surgery or go for cabbage, okay, they still have the symptoms, even though they may not be the cardiac symptoms, but they have their other symptoms of their legs, the problems with their legs, the problems with, maybe stroke or other things like that, because all that's been treated is the lesion.
Right.
You treat a patient with EECP, and diabetic patients on EECP do better than patients in the, than non-diabetic patients, or just as well.
Mm-hmm.
To express that clearly, because it is a little confusing, if you look at cabbage and bypass, and you look at a generalization or general population, diabetic patients don't do as well as that general population. If you look at EECP, the diabetic patients do as well as the general population. So that interested a bunch of doctors down at Gainesville, the University of Florida, to do a study down there. Yeah. And under Dr. Richard Conte, who's one of the best known cardiologists in the United States, he was the editor of Circulation, which is the journal for the American College of Cardiology. They did 2 studies that demonstrated that not only did EECP reduce abnormal glucose tolerance, it actually improved insulin resistance. So those are the 2 factors that diabetic patients are dealing with as they become worse and worse. If you can reverse that or stop that process, you're adding quality of life and, and hopefully a longer, healthier life to these patients.
Oh yeah, no, my guy told his wife, he said, I think I've added 2 years of quality life onto my.
Absolutely.
Life. He was
absolutely
thrilled about it. And actually he's coming back in a couple of weeks to see if he can get another 10 or 20% increase there.
Well, a lot of centers do that. After they've treated their patients, they know that these patients are still going to get older. Some of them are not going to stop their risk factors. And what they do is they schedule them for a year later. If you need to come back sooner, but at least a year from now. If you're not going to go through a full treatment, come for a booster. Some do 5 treatments, some do 10 treatments, some do, Monday, Wednesday, Friday, depends upon what the center's flexibility is. So, you know, you can work with your patient load and develop a whole sense of, you know, your center really dealing with these patients and giving them a phenomenal quality of life and keeping their symptoms either minimal or, you know, totally gone.
Well, I think our time's up for today. I would like to invite you to come back and let's talk further, because there's so much here. And I mean, just a couple of people that I've worked with, their quality of life on every level has gone up, and they're just thrilled about that. So,
Well, that's great.
Totally interested. I mean, I'm 62 and my mom's 87, and she's been on the system for a month or two now. That's why I got involved in this. And it's really funny, when she's on the system, she's broken both hips. She's walking around without her cane, no problem. When she was off the system for a week, she fell down twice. Now we've got her back on the system, and it's a lot easier on me because she's cognitively there and efficient when she's on the system. When she's off the system, it's hit or miss whether she's...
Absolutely. When patients are on the system and they've got good blood flow in their legs and stuff like that, even if they falter when they're walking, they have the ability to counter and catch themselves or hold themselves up. When they don't have that, they're totally at, you know, the, you know, they can lose their balance, whether it initiates cognitively or whether they just step on something. I mean, one of the reasons I can't use a cane is I'm not that coordinated, because I'll walk over it. But I had to learn. EECP has helped significantly in my lifestyle. I mean, there's a reason that places like Mayo Clinic, Cleveland Clinic, Cedars-Sinai, you know, I could list all over the country, places that are, you know, the universities of Florida, Colorado, California, in a number of places. You know, this is where it's grown tremendously. Internationally, it's growing tremendously. It still continues to grow because they don't have the resources to treat patients, you know, as well as they do with EECP. And because they're not as carefully watched, you know, the doctors individually can make the decision. There's a lot of more, we see a lot more off-label use as well.
Yeah, so it's huge in China and India, isn't it?
Absolutely. It was huge in China for many, many years. Now China is, when they did it in China, I'll say, for instance, in the 70s and 80s, it proliferated all over the place, and everybody was doing it, even if they were a doctor of Chinese medicine, not only Western type medicine. And that caused some people to discredit it. Now people are starting to think of this as something that should be integrated into Western medicine as either integrative or you know, comparative medicine. The Indian physicians, or the growth in India has been tremendous. One of the physicians who actually became the first distributor for Vasomedical in EECP, was here in the United States working for a cardiologist. Actually, the first center in the United States was at United Hospital in Port Chester, New York. And he was here. He was an Indian physician waiting to start his cardiology residency. So he was working for this cardiologist, and what was he doing? He was doing EECP for him. So he came to Vasomedical and he said, listen, I'm going back to India for the summer. If I sell any systems, can I get, you know, commission on it? We said, absolutely. Well, he came back with 4 orders, 2 of them at one of the biggest hospitals in India. He sold probably easily over 100 systems. Wow. To, he never came back, by the way, for his residency here, but he completed his cardiology residency in India. But he's also introduced it to Ayurvedic yoga. It's the people in India who believe in natural medicine only. The body will heal itself. Look at EECP as a way of helping the body treat itself.
Mm-hmm.
So it is a comparative or consultative type a medicine, and there are many sects in India where their top priests, there's a group in India called BAPS. Their high priest has been using it, or used it up until his death, just like 2 years ago. And he came to Vaso Medical in his, probably in his early 80s when he had congestive heart failure. We put a system in the temple, and he just passed away in his 90s. And he was a guy who traveled all over. I mean, he even in his 80s and early 90s, he did not sit in the temple in Delhi. He went to visit people, and he went to the villages and the towns. And we had to figure out a way to make an EECP system portable for him so that they could bring along basically a system and reassemble it every place he went so he could get treatment. Wow. There's just so many. There's a leader called Ravi Shankar, not the instrumentalist that played with the Beatles, but the guy who has a following of something like well over 6 to 8 million Ayurvedic yogi, people who now believe in EECP, and they've included it in their clinics.
Wow.
So, I see that happening in Russia, where I visited a number of times. I've seen it in, other places in Southeast Asia that are growing significantly. Europe has had a number of systems. The biggest problem, has been government resistance. In India, it's being absorbed by the government. The government formed what they call PPP, private-public partnership, with the distributor there to set up EECP centers in public hospitals. And in the state of Tamil Nadu, they actually paid for EECP. And they paid for it as a preferred therapy over bypass and angioplasty.
Wow.
Because these things are expensive, and
not easy to do. I mean, not everybody can perform an operation.
Well, that's it too.
Like that.
That's it too. You have to have experts, and once somebody becomes an expert, that's what they're going to want to do. Yeah. We used to say cardiologists with a catheter and a stent is like a carpenter with a hammer. Everything looks like a nail. But and I've got to give credit. Some of these places that I've mentioned, Mayo Clinic, Cleveland Clinic, Cedars, the people who are even down at the University of Florida, the biggest proponents have been invasive cardiologists, because they realize very smartly that they can't treat everybody. There is an appropriate patient for the cath lab. There's an appropriate patient for bypass. There's an appropriate patient for EECP.
Cool. Well, I want to thank you very, very much for your time.
You're
and I
welcome.
look forward to our next interview. We'll go a little bit deeper on a few of these things.
Okay.
Thank you
You
so
take
much.
care. Stay safe. Stay well.
Will do. Thanks, Larry.
Bye-bye.
Bye-bye.